CEN Written Exams Study Guide. Question 1. A patient presents with preeclampsia, headache, visual changes, epigastric pain, and elevated liver enzymes and platelets. This patient is at risk for Option A, eclampsia. Option B, HELLP syndrome. Option C, placental abruption. Option D, preterm labor. The correct answer is option B, HELLP syndrome. HELLP syndrome is a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. It presents with epigastric pain, nausea, headache, and visual changes. HELLP requires immediate delivery to prevent maternal and fetal morbidity/mortality. Magnesium sulfate is used to prevent eclampsia, and delivery is indicated. Question 2. A patient with a stroke is within the 4.5-hour window for TPA. The CEN should: Option A, obtain a CT head to rule out hemorrhage. Option B, check the blood pressure, target 185/110 mmHg. Option C, prepare for TPA administration. Option D, all of the above. The correct answer is option D, all of the above. TPA is indicated for acute ischemic stroke within 4.5 hours of onset. The protocol includes CT head to rule out hemorrhage, blood pressure control, 185/110 mmHg, and preparation for TPA administration. If the patient is a candidate, TPA is given, and the patient is monitored in a stroke unit. Question 3. A patient with mania is disruptive and not responding to verbal redirection. The patient is placed in 4-point restraints. The CEN should monitor the patient every: Option A, 30 minutes for circulation, nutrition, elimination, and mental status. Option B, 60 minutes. Option C, 15 minutes. Option D, as needed. The correct answer is option C, 15 minutes. Restrained patients require frequent monitoring to ensure safety. In ED settings, restrained patients should be monitored every 15 minutes for circulation, respirations, nutrition, elimination, and mental status. Restraints should be used only for patient or staff safety when less restrictive measures have failed. Restraint orders require a physician's order and are time limited. Question 4. Which condition is characterized by paradoxical chest wall movement during inspiration, flail chest? Option A, pneumothorax. Option B, pulmonary contusion. Option C, multiple rib fractures with a segment floating independently. Option D, cardiac contusion. The correct answer is option C, multiple rib fractures with a segment floating independently. Flail chest occurs when 3 or more adjacent ribs are fractured in 2 or more places, creating a freely moving segment. This segment moves paradoxically, inward during inspiration, outward during expiration, impairing ventilation. Pain control, oxygen, and possibly mechanical ventilation are mainstays of treatment. Question 5. A patient presents with epigastric pain radiating to the back, nausea, and elevated lipase. Which diagnosis is most likely? Option A, gastritis. Option B, pancreatitis. Option C, cholecystitis. Option D, peptic ulcer disease. The correct answer is option B, pancreatitis. Acute pancreatitis presents with epigastric pain radiating to the back, nausea, vomiting, and elevated lipase, 3 times the upper limit of normal. Common etiologies include gallstones and alcohol use. Management includes 4 fluids, pain control, NPO status, and treatment of the underlying cause. Question 6. A patient with cyanide poisoning, from smoke inhalation, presents with confusion, dyspnea, and a normal SpO2. The CEN should anticipate: Option A, sodium thiosulfate and hydroxycobalamin. Option B, oxygen only. Option C, naloxone. Option D, atropine. The correct answer is option A, Sodium thiosulfate and hydroxycobalamin. Cyanide poisoning often occurs with smoke inhalation. Symptoms include confusion, dyspnea, seizures, and lactic acidosis. SpO2 may be normal because oxygen is not utilized by the tissues. Hydroxycobalamin, vitamin B12A, is the first-line antidote, binds cyanide to form cyanocobalamin. Sodium thiosulfate is a second-line agent. Oxygen is supportive. Question 7. A patient presents with sudden, severe, and sharp pain in the right lower quadrant, nausea, and vomiting. Rebound tenderness is present. The CEN should suspect. Option A, pancreatitis. Option B, appendicitis. Option C, diverticulitis. Option D, ovarian cyst. The correct answer is option B. Appendicitis. Appendicitis typically presents with periumbilical pain that migrates to the right lower quadrant, McBurney's point, anorexia, nausea, vomiting, and fever. Rebound tenderness and guarding suggest peritoneal irritation. CT scan with contrast is the diagnostic test of choice. Surgical consultation is needed promptly to prevent perforation. Question 8. A patient has a suspected tension pneumothorax with tracheal deviation, unilateral absent breath sounds, and hypotension. What is the priority intervention? Option A, chest X-ray. Option B, needle decompression. Option C, chest tube insertion. Option D, oxygen therapy. The correct answer is option B. Needle decompression. Tension pneumothorax is a life-threatening emergency requiring immediate needle decompression, second intercostal space, mid-clavicular line, or finger thoracostomy. The condition causes mediastinal shift, impaired venous return, and shock. Chest X-ray should not delay treatment. Chest tube insertion follows needle decompression. Oxygen is adjunctive but not the priority. Question 9. A patient presents with sudden, painless vision loss in one eye. Which diagnosis is most likely? Option A, central retinal artery occlusion, CRAO. Option B, retinal detachment. Option C, acute angle closure glaucoma. Option D, optic neuritis. The correct answer is option A. Central retinal artery occlusion, CRAO. CRAO presents with sudden, painless, monocular vision loss. It is an ophthalmic emergency requiring immediate evaluation for a source of emboli. The patient may have a cherry red spot on the macula. Treatment includes ocular massage, lowering intraocular pressure, IOP, and possibly thrombolysis if the patient is within the window. Retinal detachment presents with flashing lights and floaters. Question 10. A patient presents with suspected abuse, elder abuse or child abuse. The CEN should. Option A, report the suspected abuse to the appropriate agency. Option B, confront the suspected abuser. Option C, keep the information confidential. Option D, delay reporting until the patient is discharged. The correct answer is option A. Report the suspected abuse to the appropriate agency. Suspected abuse, elder abuse, child abuse, domestic violence, or human trafficking, is mandatory reporting in all 50 states. The CEN should report to the appropriate agency, CPS, APS, or law enforcement. The CEN should not confront the abuser, this is the role of the social worker or law enforcement. Confidentiality does not apply in cases of suspected abuse. Question 11. A patient with a history of opioid use disorder presents with respiratory depression and constricted pupils. Which medication should the CEN anticipate? Option A, naloxone, Narcan, 0.4 mg 4. Option B, flumazenol, romazicon. Option C, naltrexone. Option D, buprenorphine. The correct answer is option A. Naloxone, Narcan, 0.4 mg 4. Naloxone is the opioid antagonist used to reverse opioid overdose, which presents with respiratory depression, pinpoint pupils, and decreased consciousness. The dose may be repeated if there is no response. Flumazenil is for benzodiazepine overdose. Naltrexone and buprenorphine are used for maintenance therapy, not reversal. Airway management is the priority. Question 12. A patient with a history of COPD is being discharged. The CEN should provide education on Option A, smoking cessation. Option B, use of bronchodilators. Option C, the importance of pulmonary rehab. Option D, all of the above. The correct answer is option D, all of the above. Patient education is a key part of CEN practice. COPD discharge teaching includes smoking cessation, correct use of bronchodilators, pulmonary rehabilitation, and monitoring for signs of infection. This is part of professional nursing responsibility. Question 13. A patient presents with heat stroke, temperature 40.5 degrees Celsius, 105 degrees Fahrenheit, confusion, and hot, dry skin. The priority intervention is Option A, 4 fluids. Option B, cooling measures, ice packs, cold water immersion. Option C, antipyretics, acetaminophen. Option D, neurological assessment. The correct answer is option B, cooling measures, ice packs, cold water immersion. Heat stroke is a life-threatening emergency requiring rapid cooling. The priority is to lower the core temperature as quickly as possible using ice packs, cold water immersion, or evaporative cooling. Antipyretics are ineffective in heat stroke because the pathophysiology is not hypothalamic. Cooling should be done until the core temperature reaches 38.9 degrees Celsius, 102 degrees Fahrenheit. 4 fluids are supportive. Question 14. A patient with increased intracranial pressure, ICP, from a head injury has a Glasgow Coma Scale, GCS, of 8. Which finding is most concerning for elevated ICP? Option A, Cushing's triad, hypertension, bradycardia, irregular respirations. Option B, tachycardia and hypotension. Option C, dilated pupils with brisk response. Option D, restlessness. The correct answer is option A, Cushing's triad, hypertension, bradycardia, irregular respirations. Cushing's triad, hypertension, bradycardia, and irregular respirations, is a classic, late sign of increased ICP, indicating brainstem compression and imminent herniation. This requires emergent intervention, elevating the head of the bed to 30 degrees, hyperventilation, target PaCO2 30 to 35 mmHg, osmotic therapy, mannitol or hypertonic saline, and possibly surgical decompression. Tachycardia and hypotension suggest shock, not elevated ICP. Unilateral pupillary dilation suggests herniation. Question 15. A patient with a communication barrier, e.g., non-English speaking, deaf, requires interpretation. The CEN should Option A, use a trained medical interpreter. Option B, use a family member. Option C, use a bilingual staff member. Option D, use a phone interpreter. The correct answer is option A, use a trained medical interpreter. Effective communication is essential for patient safety and ethical care. A trained medical interpreter, in person, phone, or video, should be used to communicate with patients who have a language barrier or are deaf. Family members or friends should not be used for medical interpretation due to the potential for errors and breaches of confidentiality. Bilingual staff who are trained as interpreters are acceptable. Question 16. A patient with bipolar disorder in a manic episode is speaking rapidly, pacing, and expressing grandiose ideas. The patient is not responding to redirection. The CEN should Option A, put the patient in a quiet, low-stimulation room. Option B, administer haloperidol 5 mg IM. Option C, call security immediately. Option D. Discharge the patient home with a referral. The correct answer is option A. Put the patient in a quiet, low-stimulation room. Patients in a manic episode benefit from a quiet, low-stimulation environment to reduce overstimulation and agitation. Redirection and verbal de-escalation should be attempted first. If the patient is a danger to self or others, medications, haloperidol, olanzapine, or restraints may be needed, but the least restrictive measures should be used initially. Discharge is not appropriate in an acute manic episode with safety concerns. Question 17. Which of the following is the most effective approach for de-escalating an agitated patient? Option A. Use a firm, loud voice to establish authority. Option B. Maintain a calm, non-threatening tone and provide personal space. Option C. Immediately call security for assistance. Option D. Restrain the patient. The correct answer is option B. Maintain a calm, non-threatening tone and provide personal space. De-escalation is a key skill for emergency nurses. It involves using a calm, non-threatening tone, maintaining personal space, acknowledging the patient's feelings, and allowing them to express themselves. Firm, loud voices can escalate agitation. Security may be needed if de-escalation fails, but it should not be the first approach. Restraints are a last resort. Question 18. A patient with a suspected hemorrhagic fever, e.g., Ebola, should be managed with Option A. Strict contact and droplet precautions. Option B. Airborne precautions. Option C. Standard precautions. Option D. Enhanced contact and droplet precautions. The correct answer is option D. Enhanced contact and droplet precautions. Hemorrhagic fevers, Ebola, Marburg, Lassa, require a high level of isolation, enhanced contact and droplet precautions, including double gloves, impermeable gowns, face shields, and shoe covers. These patients should be in a single room with dedicated equipment. The CEN should follow the facility's protocol for high-consequence infectious diseases. Airborne precautions may also be used in some settings. Question 19. Which imaging study is preferred for stroke evaluation within the first 24 hours? Option A. CT angiography, CTA. Option B. MRI with diffusion-weighted imaging, DWI. Option C. CT perfusion, CTP. Option D. All of the above depending on the clinical scenario. The correct answer is option D. All of the above depending on the clinical scenario. Stroke evaluation may include non-contrast CT to rule out hemorrhage, CTA to assess large vessel occlusion, CT perfusion to assess penumbra, and MRI DWI for early infarction detection. The choice depends on the clinical scenario, time since last known well, and availability. For thrombectomy candidates, CTA is essential to assess vessel patency. Question 20. A patient who is depressed and suicidal is admitted to the ED. The CEN should. Option A. Ask the patient if they have a plan to harm themselves. Option B. Avoid asking about suicide to prevent giving the patient ideas. Option C. Ask the patient only about feelings of hopelessness. Option D. Ask the patient about their mood. The correct answer is option A. Ask the patient if they have a plan to harm themselves. Asking about suicidal ideation and a specific plan is essential for risk assessment. It does not give the patient ideas but helps the healthcare team determine the level of risk and implement appropriate safety measures. Direct, non-judgmental questioning is recommended. Evaluation of intent, plan, and means is critical in assessing suicide risk. Question 21. A patient with SVT has failed vagal maneuvers. The CEN should prepare to administer. Option A. Adenosine 6 mg 4 push. Option B. Atropine 1 mg 4. Option C. Epinephrine 1 mg 4. Option D. Amiodarone 300 mg 4. The correct answer is option A. Adenosine 6 mg 4 push. Adenosine is first line for stable SVT. It is given as a rapid forepush, 1 to 2 seconds, followed by a 20 ml saline flush. Atropine is for bradycardia. Epinephrine is for cardiac arrest. Amiodarone is for ventricular arrhythmias. Adenosine works by transiently blocking AV node conduction. Question 22. A patient presents with a bowel obstruction, nausea, vomiting, abdominal distension, and obstipation. Which imaging study is preferred? Option A, abdominal X-ray. Option B, CT scan with oral contrast. Option C, ultrasound. Option D, MRI. The correct answer is option B. CT scan with oral contrast. CT with oral and for contrast is the preferred imaging for suspected bowel obstruction, as it can identify the location, cause, and complications of obstruction. Abdominal X-ray may show air fluid levels but lacks specificity. Ultrasound and MRI are less sensitive. Management includes NPO status, NG tube placement, for fluids, and surgical consultation. Question 23. A patient with hypothermia, core temperature 30 degrees Celsius, is unresponsive. The CEN should: Option A, rewarm the patient with active external rewarming, e.g., warm blankets. Option B, rewarm with active internal rewarming, e.g., warm for fluids, warm humidified oxygen. Option C, administer 4 antibiotics. Option D, defibrillate for VF. The correct answer is option B. Rewarm with active internal rewarming, e.g., warm for fluids, warm humidified oxygen. Hypothermic patients with temperatures below 32 degrees Celsius are at risk for cardiac arrest. Active internal rewarming is the priority. External rewarming can cause afterdrop or rewarming shock, peripheral vasodilation causing hypotension. Defibrillation may be attempted for VF, but if the patient is severely hypothermic, the heart may not respond until rewarming is initiated. Management is supportive. Question 24. A patient with a pulmonary embolus is receiving heparin. The CEN should monitor for which complication? Option A, bleeding. Option B, heparin-induced thrombocytopenia, HIT. Option C, allergic reaction. Option D, all of the above. The correct answer is option D, all of the above. Heparin has multiple complications: bleeding, due to anticoagulation, HIT, immune-mediated thrombocytopenia, and allergic reactions. Monitoring includes APTT, for therapeutic effect, platelet count, for HIT, and bleeding assessments. HIT should be suspected if the platelet count drops significantly. Alternatives include direct thrombin inhibitors, argatroban, if HIT occurs. Question 25. A patient with an amputation of the finger is brought to the ED. The amputated part should be: Option A, placed directly on ice. Option B, wrapped in moist gauze and placed in a sealed bag, then on ice. Option C, placed in a dry bag. Option D, discarded. The correct answer is option B. Wrapped in moist gauze and placed in a sealed bag, then on ice. The amputated part should be wrapped in moist gauze, placed in a sealed plastic bag, or container, and then placed on ice, not directly on the ice. This preserves the tissue for potential reimplantation while preventing thermal injury from direct ice contact. The CEN should ensure rapid transport with the patient and the amputated part.